Well, thank you. I think I will start just talking via the video link. Well, thank you so much for inviting me to this session. And the issue of total care or total health or integrated care is, as we know, very important, and especially in these days. I will start talking a little about my previous work, like you said, that I did in Region Skåne in southern Sweden, where we set up an integrated care project and a hospital working together with the municipality and primary care. And then I will talk a little bit about my current employer, Ramsay Santé, and what we're thinking about transforming that organization. And finally, just a little bit about the COVID situation as well. But I will start in the micro level. 15 years ago, I worked as emergency doctor at a hospital here in southern Sweden. And when you do that, I work in internal medicine. And when you work that, you see quite a lot of old people. Most of our patients are over 70 or 80 years old. And we had especially one patient that we saw quite a lot of. She was 94 years old and she had everything. She had everything. She had diabetes, COPD, heart failure, dementia. She lived in a nursing home, and her family, her children and grandchildren lived in Australia. And this patient visited us at the ER almost twice a week, at least several times a month, for different issues, different acute or emergency conditions that she had to be brought to the emergency ward for. And sometimes we admitted her into the hospital. We kept her for a couple of days. We couldn't do very much. And then she was sent home to her nursing home again. And after a couple of days, she returned again. And then one night at 4 a.m. in the morning, she arrived at the hospital in an ambulance, lights flashing, and was brought into the ER room, the emergency room, you know, with all the bright lights and a lot of people there waiting to receive her. And she died. She died there on the table in the emergency room. And this experience hit me quite hard. I'm still a little bit moved by it, actually, because it felt so wrong that a 94-year-old woman should have to spend her last 6 months of her life going back and forth from the nursing home to the hospital, and then to die in the middle of the night in an emergency ward. I think all of us who worked with this patient felt that we had failed her, in some way, that she deserved better. And when we investigated this sort of incident, we found that no one had actually done anything wrong. The primary care units had done what they should do. The hospital, we had done what we should, and the municipality had done what they should do. So the problem here wasn't the different organizations in their silos. The problem was that we were not working together. Together we could not see what was best for this patient. And as I said, that hit me quite hard, and that's when I sort of realized the importance of transforming the healthcare system into a more integrated one. So that's my sort of micro story, and I will now share my presentation. I think this story of mine is quite similar to many people who has worked in healthcare. Right. So these are the challenges. We have many challenges, but these are some of the challenges for the Swedish healthcare system. We have an aging population. We have a demographic crisis, if you want to. We have in the next 10 or 20 years, we will have a severely increase in people aged 80 or over, and at the same time, we will be fewer and fewer people working. So this is an issue, and as we know, most people consume most of their healthcare needs at the end of their lives when they're 80 years or older or more. We also see a lack of cooperation between different parts of our healthcare system. It's fragmented. We have a primary care system, we have municipal care, when we have the hospitals. And even within the hospitals, we have sometimes lack of cooperation, as I suppose many people working in hospitals know. And this reduces the quality of the care we deliver, and it makes it more expensive. We also have problems in delivering care at the right level, because sometimes we have patients coming to the emergency ward that shouldn't really be there, and we have patients in hospital that shouldn't be there. But we also sometimes send people home from the hospital much too soon, and the municipality can't really take care of them. And the only thing that keeps us together, the parts of the healthcare system, is that we blame each other for the problems. The hospital blames the primary care units, they blame the municipality, and the municipality blames the hospital. And lastly, we have staffing issues. We will have trouble getting people to work in healthcare. Right now in Sweden, it's very difficult to recruit nurses. Might change now with the COVID situation, where people has sort of realized the importance of healthcare. But we see that we have to find new ways of working to get partly to be more effective, but also to get people to stay and to enjoy working in healthcare, because we have quite a lot of burnout. And as I know this from experience, these challenges are more or less the same in the entire sort of Western world. It's the same in Japan or in France or in the US or in Australia. So this is something that faces us all. So I worked before in a small hospital for Region Skåne in the northwestern part of southern Sweden, and it's called Ängelholm, City of Angels. Well, we saw this problem. We were a small hospital that needed to change, and we had the same problem as I described with my elderly patient. We had this all the time in this hospital. So we sat down together with the municipality and primary care and said, okay, can we do something about that? And we discussed with our politicians. And in 2013, we got the okay to start a pilot that was called Hälsostaden. And that's Health City. And that was supposed to be, in the beginning, one organization where the municipality, the public hospital, and public and private primary care went together as a unit. It later developed into more like a cooperation or a joint venture between our different parts of the system. And we started thinking about what is it that we really want to deliver? What kind of care is it that we want to deliver to not our patients, but to our citizens? What has the citizen actually paid for with their taxes? And we developed this concept of sensible care, or vettig vård in Swedish. And the focus, what we saw was that the healthcare of the future has to be much more person-centered. We discovered that our system today is very much centered on our organizations and the needs of our organizations. But for patients with complex needs, we have to be much more patient-centered. This is not news, of course, but it's very difficult to actually do. We also said that we have to be proactive. Healthcare professionals, me included, are trained to be reactive. We wait until something breaks down and then we mend it. In Sweden, a doctor is called, or you could almost translate it to a healer. And in order to heal something, it has to be broken. It has to be some problem with it. So to transform into how can we work more upstreams? How can we prevent people from actually having to come to the hospital? How can we prevent? Well, there's so many things we could work on, but that was the issue. We should always try to find areas where we could together work upstreams. And finally, it had to be integrated. We had to find a way to integrate our different healthcare systems, because like I said before, the patient, the normal taxpayer, in Sweden, as you know, most of healthcare is based on taxes. But what we pay for as taxpayers is not for different points of care where you can sort of have your problem solved. It's if you have a stroke, what you want to be able to do is to walk again. It doesn't matter how good the hospital is or the municipality is to take care of me afterwards. It has to stick together. What I've paid for is actually to be able to walk again after a stroke. And in order to do that, we must work together, integrate. And all this must be supported by new technology and IT solutions. The name Sensible Care actually came about because I was explaining to my grandmother. She's died. She's dead now. But she asked me. I was working as a manager when we were setting this up, and not as a practitioner. And she asked me, Carl-Johan, what are you actually doing now when you're not a real doctor? And I tried to explain to her that we're trying to, get healthcare to work the way you think it should work. And she said, that's just sensible care. So we nicked that. So what we try to do, it was obviously much more complex, but I will try to describe it. We looked at our patients and tried to segment them into sort of different needs. There are different levels of complexity. And in the top of this pyramid, you see the patients with high complexity and multiple medical needs. My patient that I talked about earlier is a representative in this group. Then we have patients with chronic conditions that sometimes need acute intervention. This could be a patient with heart failure that is stable, but sometimes when they have could just be a cold or something, it makes them worse and they need acute intervention. And then we have, basically mostly healthy, but they have some symptoms and risk factors. This could be patients with osteoporosis that haven't yet broken their bones yet. And lastly, we have the healthy population that we all think that we are a part of, but we all have to work with to quit smoking and to lose 1 or 2 kilos. So that's that was sort of where we started. And we sat down with, like I said, representatives from the municipality and the primary care units and the hospital, and we work together every week. We have a steering group for Hälsostaden, and we met every week, and we sat together and we looked at what can we do together in different areas. And one of the most important things was were these patients with high complexity, because they are only about 10% of the total patient stock, the population stock, but they consume about 80 or 90% of the total healthcare costs. So these are patients that we found that if we can do something to treat these patients better together, we could improve the quality of care, but we could also reduce cost. And I will focus on these patients today. I will come back to just a little bit what we did in the other parts of the pyramid later. So we looked into patient cases like the one I talked about earlier, where that were the patient I saw in the emergency ward, patients that were going back and forth to the hospital. And we asked the nurses working out in the nursing homes, why are you sending them in? And they said, we don't get enough medical support. They were supposed to, and sometimes they got support from primary care and from the hospital, but it was difficult for them. Some of these nurses used about 20% of their time just trying to get a hold of a doctor to ask them, what should I do with these patients? There's quite a lot of responsibility for them. So in order to be more safe than sorry, they sent the patients to the hospital. The patients had also quite complex needs. Sometimes they needed IV drips, they needed blood, they needed intravenous antibiotics, and that of course had to be taken care of in the hospital, at least in Sweden. So we asked the nurses in the municipality, in the nursing homes, what if we try to set up a system where the patient doesn't have to come to the emergency ward, but the emergency ward comes to the patient? And that's what we tried to set up. We set up mobile care teams. There was multi-professional teams. There were doctors from the hospital that they were used to work in our hospital wards and in the emergency room that actually could go out and see these patients out of hospital. And with them, they had a nurse from primary care or from the emergency ward that could assist them and help with IV drips and stuff. And we had one acute team that went sort of like emergency team that could go out the same day. But after a while, we noticed that, okay, many of these patients are the same. So we also started a team that took care of planned visits. Right. So when we evaluated this, we found that we could prevent 98% of visits to the emergency ward. Some of them had to come in, of course, and we could prevent 99% of hospitalization. So what we have been doing before with these patients is that we've been taking them into hospital where we didn't provide value for these patients. But by setting up the system, we could actually provide value and do it much cheaper than we could in the traditional way. And we could actually reduce hospital beds by almost 10% doing this. Setting up the team cost about 700 euros a year, and the money we saved from shutting down hospital beds was about 2 million euros. So this is just one example of what we did. And the challenges were to merge cultures, to work together, hospital, primary care, and municipal. IT, of course, it was difficult to scale up. The reimbursement model had to be support this. We had legal issues, but most importantly, it was giving up power. But because we, all of us, in the management of both the hospital, the primary care, and the municipality, we had to release power to our staff to make them design the new work streams. And one of the most important findings we had was that we need to establish arenas for building relationships. If we want to have a total healthcare system, an integrated system, we have to trust each other. There has to be finance, reimbursement, IT, and everything. But if we don't trust each other, we have a problem. And the way we solved it was a very Swedish way. We solved it with fika, coffee and a cinnamon bun. And we found that this really worked very well. In the start of every meeting, just coffee and a cinnamon bun, and we start talking about our joint problems. And that was actually an icebreaker that built trust. So that's one of my best lessons learned is don't ever underestimate the power of a fika. So that was the case of Hälsostar. And I have lots of more examples from what we did from a total healthcare perspective on working with prevention and loneliness and stuff like that. But I will leave that now and start talking about Ramsay. This is my current employer. I work as a medical innovation director, and Ramsay is the second largest private care provider in Europe. And we have about 150 hospitals in France. But in 2018, Ramsay bought Capio. And Capio in Sweden is mostly primary care. So there's about 100 primary care units. So Ramsay in France, there's a lot of hospitals. In Sweden, we have a lot of primary care units. And what we are looking for in the future is to move our organization from being reactive, from being just a receiver of patients in our hospitals in France, to being more proactive, to move out of hospital. To do this by setting up a digiphysical new digiphysical healthcare, where we develop both digital care and physical care. And physically, we have to be present out of hospital, but we also need to have digital solutions for the future. So our main objective right now is to try to transform this organization into an integrated care system where we take public responsibility as well, because I think this is needed from also private healthcare providers in the future. And just briefly, I think I've just run over my time, maybe for one, or maybe I have a minute left. Some short, very short learnings from COVID-19. We've seen, as I think most have, an accelerated use of digital consultations in France and Sweden. The need for it has obviously exploded. And for example, our CapU Go, this is our primary care online service, a fully digital primary care service with a chat function that has increased by over 100% the use of that. And we also find that people aren't as afraid as before with using digital healthcare and digital solutions and teleconsultations. And the second part is that Ramsay Santé's hospitals in France has been a very integrated part of the French crisis management. So these are private hospitals, tax funded, but they are private. And they have been a part of the crisis management where we have increased our number of ICU beds, working together with the management. Also taken an increased responsibility for post-COVID rehabilitation, which we see as a really big issue after this crisis. And also mental health. There's quite a lot of almost post-traumatic syndrome from people being hit by this disease. We've also set up more than 20 research projects relating to the corona treatment. What I hope the lasting effect of this will be is that we will see the need to integrate our systems more. We have to work together to bring about a total healthcare system. And I think that the private sector of healthcare can be a very significant part of this. The thing that stops us is sometimes the reimbursement models. And what I think we will take away also is the digital maturity, of course, where we will have both in our staff, but in our patients as well, we see that they are much more keen on using digital tools to provide healthcare. And hopefully our political stakeholders will see this as well and encourage and also reimburse digital consultations as they do physical ones. So that was my presentation. Thank you.